Atherosclerosis. Welcome to this lecture for MBBS students on atherosclerosis. Please hit the subscribe button if you haven't yet subscribed to the channel. Atherosclerosis. Atherosclerosis is a progressive inflammatory disorder of the arterial wall that is characterized by focal lipid-rich deposits of atheroma. Atherosclerosis can affect any artery in the body. When it occurs in the heart, it may cause angina, MI and sudden death, in the brain, stroke and transient ischemic attack, and in the limbs, claudication and critical limb ischemia. Occult coronary artery disease is common in those who present with other forms of atherosclerotic vascular disease, such as intermittent claudication or stroke, and is an important cause of morbidity and mortality in these patients. Pathophysiology of atherosclerosis. Atheromas remain clinically silent until one of the following occurs. They become large enough to impair tissue perfusion. Atheroma ulcerates and disrupts, resulting in thrombotic occlusion or distal embolization of the vessel. The clinical manifestations of atherosclerosis depend upon the site of the lesion and the vulnerability of the organ supplied. Early atherosclerotic lesions have been found in the arteries of victims of accidental death in the second and third decades of life. Nevertheless, clinical manifestations often do not appear until the sixth, seventh or eighth decade. Early atherosclerosis is seen as fatty streaks. Fatty streaks tend to occur at sites of shear stress, such as bifurcations, and are associated with abnormal endothelial function. Inflammatory cells, mainly monocytes, bind to receptors on endothelial cells and migrate into the intima. Once inside intima, they take up oxidized low-density lipoprotein particles and become lipid-laden macrophages or foam cells. Extracellular lipid pools appear in the intimal space when these foam cells die and release the contents. Smooth muscle cells migrate into the intima in response to cytokines and growth factors produced by the activated macrophages and change from a contractile to a repair phenotype, trying to stabilize the atherosclerotic lesion. If successful, the lipid core is covered by smooth muscle cells and matrix, producing a stable plaque that remains asymptomatic until it becomes large enough to obstruct arterial flow. Advanced atherosclerosis. If inflammation predominates, the plaque becomes unstable and may be complicated by ulceration and thrombosis. The activated macrophages release cytokines like interleukin-1, tumor necrosis factor alpha, interferon gamma, platelet-derived growth factors, and matrix metalloproteinases. These cytokines cause the degradation of collagen cross-struts and intimal smooth muscle cells. The protective fibrous cap is thinned, making the lesion vulnerable to mechanical stress that ultimately causes erosion, fissuring or rupture of the plaque surface. The contents of plaque are highly thrombogenic, and once the integrity of the plaque is breached, platelet aggregation occurs and it triggers thrombosis, obstructing the arterial lumen, resulting in infarction or ischemia of the affected organ. This common mechanism underlies acute lower limb ischemia, MI, and stroke. The number and complexity of arterial plaques increase with age and with risk factors, but the rate of progression of individual plaques is variable. There is a complex and dynamic interaction between mechanical wall stress and atherosclerotic lesions. Vulnerable plaques have a lipid-rich core and a thin fibrocellular cap. In contrast, stable plaques have a small lipid pool and a thick fibrous cap, calcification and lot of collagenous cross-struts. Fissuring or rupture tends to occur at sites of maximal mechanical stress, particularly the margins of an eccentric plaque, and may be triggered by a surge in BP, such as during exercise or emotional stress. Surprisingly, many such plaque events are subclinical that heal spontaneously, allowing thrombus to become part of the growing lesion and further obstructing the flow in the artery. Atherosclerosis may induce complex changes in the media that lead to arterial remodeling. Some arterial segments may slowly constrict, negative remodeling, whilst others may gradually enlarge, positive remodeling. These changes are important because they may amplify or minimize the lumen encroachment by atheroma. Risk factors for atherosclerosis. The importance of many risk factors has been defined in studies and clinical trials, but unknown factors account for up to 40% of the variation in risk from one person to the next. A monozygotic twin of an affected individual has an 8-fold increased risk, and a dizygotic twin a 4-fold increased risk of dying from CAD compared to the general population. The effect of risk factors is multiplicative rather than additive. It is also important to distinguish between relative risk and absolute risk. Thus, a man of 35 years with a high plasma cholesterol who smokes 40 cigarettes a day is relatively much more likely to die from coronary disease within the next decade than a non-smoking woman of the same age with a normal cholesterol. But the absolute likelihood of his dying during this time is still small, high relative risk, low absolute risk. Age and sex. Age is the most powerful independent risk factor for atherosclerosis. Premenopausal women have lower rates of disease than men, although this sex difference disappears after the menopause. Also, it is important to note that hormone replacement therapy has no role in the prevention of coronary heart disease, and isolated estrogen therapy may even increase the risk of cardiovascular events. Family history. Atherosclerotic vascular disease often runs in families, due to a combination of shared genetic, environmental and lifestyle factors. The most common inherited risk characteristics, hypertension, hyperlipidemia, diabetes mellitus, are polygenic. A positive family history is defined as presence of clinical problems, example CAD and stroke, in first-degree relatives occurring at relatively young age, that is less than 50 years for men and less than 55 years for women. Smoking. This is probably the most important avoidable cause of atherosclerotic vascular disease. There is a strong, consistent and dose-linked relationship between cigarette smoking and ischemic heart disease, especially in younger, less than 70 years, individuals. Hypertension. The incidence of atherosclerosis increases as BP rises, and this excess risk is related to both systolic and diastolic BP as well as pulse pressure. Antihypertensive therapy reduces cardiovascular mortality, stroke and heart failure. Hypercholesterolemia. Risk rises with increasing serum cholesterol concentrations. Lowering serum total and LDL cholesterol concentrations reduces the risk of cardiovascular events, including death, MI, stroke and coronary revascularization. Diabetes mellitus. This is a potent risk factor for all forms of atherosclerosis and is often associated with diffuse coronary artery disease that is difficult to treat. Insulin resistance, normal glucose with high levels of insulin, is associated with obesity and physical inactivity, and is a risk factor for coronary heart disease. Glucose intolerance accounts for a major part of the high incidence of ischemic heart disease in South Asians. Hemostatic factors. Platelet activation and high levels of fibrinogen are associated with an increased risk of coronary thrombosis. Antiphospholipid antibodies are associated with recurrent arterial thromboses. Physical activity. Physical inactivity roughly doubles the risk of coronary heart disease and is a major risk factor for stroke. Regular exercise, brisk walking, cycling or swimming for 20 minutes 2 or 3 times a week, has a protective effect which may be related to increased serum HDL cholesterol concentrations, lower BP, and collateral vessel development. Obesity. Obesity, particularly if central, is an independent risk factor, although it is often associated with other adverse factors such as hypertension, diabetes mellitus and physical inactivity. Alcohol. Moderate alcohol consumption is associated with reduced rates of coronary artery disease. Excess alcohol consumption is associated with hypertension and cerebrovascular disease. Other dietary factors. Diets deficient in fresh fruit, vegetables and polyunsaturated fatty acids are associated with an increased risk of cardiovascular disease. The introduction of a Mediterranean-style diet reduces cardiovascular events. However, dietary supplements, such as vitamin C and E, beta-carotene, folate and fish oils, do not reduce cardiovascular events and, in some cases, have been associated with harm. Personality. Certain personality traits are associated with an increased risk of coronary disease. Nevertheless, there is little or no evidence to support the popular belief that stress is a major cause of coronary artery disease. Social deprivation. Health inequalities have a major influence on cardiovascular disease. The impact of established risk factors is amplified in patients who are socially deprived, and current guidelines recommend that treatment thresholds should be lowered for them. Primary prevention of atherosclerosis. Two complementary strategies can be used to prevent atherosclerosis in apparently healthy but at-risk individuals. Population and targeted strategies. The population strategy aims to modify the risk factors of the whole population through diet and lifestyle advice, on the basis that even a small reduction in smoking or average cholesterol, or modification of exercise and diet will produce worthwhile benefits. Some risk factors for atheroma, such as obesity and smoking, are also associated with a high risk of other diseases and should be actively discouraged through public health measures. Legislation restricting smoking in public places is associated with reductions in rates of MI. The targeted strategy aims to identify and treat high-risk individuals who usually have a combination of risk factors and can be identified by using composite scoring systems. It is important to consider the absolute risk of atheromatous cardiovascular disease that an individual is facing before contemplating specific antihypertensive or lipid-lowering therapy, because this will help to determine whether the possible benefits of intervention are likely to outweigh the expense, inconvenience and possible side effects of treatment. For example, a 65-year-old man with an average BP of 150/90, who smokes and has diabetes mellitus, a total versus HDL cholesterol ratio of 8 and left ventricular hypertrophy on ECG will have a 10-year risk of CHD of 68% and a 10-year risk of any cardiovascular event of 90%. Lowering his cholesterol will reduce these risks by 30%, and lowering his BP will produce a further 20% reduction. Both would obviously be worthwhile. Conversely, a 55-year-old woman who has an identical BP, is a non-smoker, does not have diabetes mellitus and has a normal ECG and a total versus HDL cholesterol ratio of 6 has a much better outlook, with a predicted CHD risk of 14% and cardiovascular risk of 19% over the next 10 years. Although lowering her cholesterol and BP would also reduce risk by 30% and 20% respectively, the value of either or both treatments would clearly be borderline. Secondary prevention. Patients who already have evidence of atheromatous vascular disease are at high risk of future cardiovascular events and should be offered treatments and measures to improve their outlook. The energetic correction of modifiable risk factors, particularly smoking, hypertension and hypercholesterolemia, is particularly important because the absolute risk of further vascular events is high. All patients with coronary heart disease should be given statin therapy irrespective of the serum cholesterol concentration. BP should be treated to a target of is less than or equal to 140/85. Aspirin and ACE inhibitors are of benefit in patients with evidence of vascular disease. Beta blockers benefit patients with a history of MI or heart failure. Many clinical events offer an opportunity to introduce effective secondary preventive measures. Patients who have just survived an MI or undergone bypass surgery are usually keen to help themselves and may be particularly receptive to lifestyle advice, such as dietary modification and smoking cessation. With this we come to the end of this lecture on atherosclerosis. Hope you enjoyed it.